Good afternoon. It's Dr. Kevin Herman here from American Endovascular and Amputation Prevention to talk about limb salvage. Specifically, we entitled this presentation, Limb Salvage Requires Diligence. And I think it's very important for both the physician, the patient, patient's family, caregivers, and other physicians involved in the process in order to get fantastic results. And for limb salvage, it really does require diligence, and we'll show that through this case. This is a 69-year-old male with multiple cardiovascular risk factors who was referred to us 2 months status post amputation of the right great toe region due to osteomyelitis. He had continued non-healing at the amputation site. His past medical history was significant for hypertension, diabetes mellitus, hyperlipidemia, and a prior left toe amputation. So we have a patient who is non-currently smoking, who is optimized on his antiplatelet regimen with aspirin and Plavix, although the simvastatin, the cholesterol-lowering medication, is only at 20. He's also on metformin, glipizide, Tradjenta, and amlodipine. So this is a patient with a diagnosis of peripheral arterial disease, and specifically critical limb threatening ischemia, or CLTI, or formerly known as critical limb ischemia, as evidenced by both the non-healing wound at the right and a prior amputation in the left foot. This is a clinical image upon the day of presentation to us showing the non-healing wound at the amputation site. Patient's plan for this will be to increase the patient's statin, maintain the antiplatelet therapy. We will consider other antiplatelets further down the road, including Pletal, and nutrition discussion, arterial imaging at the time of the visit, and possible setting up the patient for an angiogram. Upon the arterial imaging, we found the patient to have what appeared to be a 50 to 75% stenosis of tibial-peroneal trunk and distal popliteal artery with relatively low flow in the posterior tibial artery. Keep that in mind as we go through the case. There's minimal to moderate wall calcification seen as well. So we planned for a right lower extremity angiogram, which was then performed on 12/1/2020. On these initial angiograms, you see, and these are the below knee vessels. I'll use my arrow to show the popliteal artery feeding the anterior tibial artery, the tibial-peroneal trunk, which goes into the peroneal artery, and over here, it's the origin of the posterior tibial artery. And then this slide shows us that the area of pathway of expected blood supply, which is occluded in this patient, as you see here. And this is the area that we will attempt to revascularize in order to perform a complete revascularization of the plantar pedal loop, which in this patient is completely occluded, and would like to drive better blood flow towards that wound base, which has been non-healing for over 2 months. You see here a nice clinical scenario of the patient's foot projection, the lateral view, and you can compare it to right here, where there is some wound blush at the location of the wound. Technically speaking, during the procedure, and I thought this was an interesting slide to discuss, which shows nested catheters for support. We have our catheters and wires down through the tibial-peroneal trunk and abutting the origin of that posterior tibial artery, which occludes. Through the larger base catheter, we have a smaller microcatheter and a thin wire that will try to traverse the plane, either through the occluded blood vessel or through what we would call the subintimal space, in order to try to advance the catheter and wire system down to the foot in hopes of re-entering into a patent vessel down below. We use a technique in this case called road mapping in order to light up the blood vessels and to stay on pulse the entire time that we can see the exact area that we need to traverse. Here's a photographic image from the case as we progress with our smaller catheter, the microcatheter and wire, down distally to about the ankle, where we see a very thin thread of contrast filling a very diseased blood vessel at the very distal posterior tibial artery at the level of the ankle. And this would be our re-entry site for the vessel where it is patent. And again, this was part of the intraprocedural angiogram. Once re-entry occurs distally at the patent vessel, we then perform our intervention. And here the post-intervention, where we're driving better blood flow going down towards the foot. Specifically, we see here the posterior tibial artery, which was the vessel that was intervened on, is now patent in the calf area and all the way down into the foot, where it is now patent as the common or lateral plantar arteries, and through the plantar pedal loop circulation to improve blood flow overall to that wound base. Here's a above and below comparison on the initial angiogram showing the occluded vessel in the posterior tibial artery. And now you can see the patent blood vessel going down, and the exact difference here where there is occlusion of the plantar vasculature and the occluded plantar pedal loop. And here we have the patent vessels. So we brought the patient back 1 week post-procedure. The wound seemed to be improving overall, and we were happy with our results so far. But at 6 weeks post the procedure, after discussion with the wound care physician and the patient, we brought the patient back for additional arterial imaging, as the wound really had stalled in its healing phase, as you could see the progression from the 8th to January 5th. At that point, another imaging study was performed, which although showed there was blood flow overall, it was diminished, and there were areas of restenosis, which is to be expected in at least up the patients, family, and the physicians, that there is a very decent chance that sometimes these patients will need to have repeat interventions either on the same blood vessel, or occasionally we can have staged interventions where one blood vessel we thought might be enough, but we really need to revascularize a second blood vessel, which is kind of what we're doing in this case here. And this is the initial angiogram showing, again, residual stenosis in that location of the anterior tibial artery takeoff at the distal popliteal artery. The posterior tibial artery was patent, but diseased inside. And we have special cameras also called intravascular ultrasound, which can actually give us a better look and see what the blood vessel looks like and get a better size appropriately. So in the second procedure, just using some technical components we called kissing balloon techniques. As you can see here, we have one balloon that goes down towards the anterior tibial artery from the popliteal artery, and one balloon from the popliteal artery going all the way down through the posterior tibial artery, and prior to that, the tibial-peroneal trunk. And we call this kissing balloon, as it looks like they're basically kissing each other. And we like to do that for several different reasons. One of them is that in case we balloon one side, we don't shift plaque into the other side and potentially occlude that. The second and third pictures here on the image show us the plantar pedal loop being intervened on in both the lateral and in the AP views. So here's a collage of the different phases of healing over some time. And finally, we have complete wound healing in this patient after diligent wound care, diligent revascularization, diligent follow-up, as well as change in medication regimen. As mentioned, limb salvage needs diligent medical management, wound management, vascular management. We have to be diligent about the expectations, and it really is a multidiscipline approach. Thank you.